Hey everyone, hi, I am Rashmika. Today I am going to discuss about the topic gastroesophageal reflux disease. It is a gastrointestinal disease which is mainly seen in the upper GI. Here we can see the overview of GERD which include symptoms like chronic cough, odynophagia, dysphagia, chest pain, heartburn and also the risk factors obesity, pregnant women, hiatal hernia. Even some dietary sources can also trigger the acid reflux factors like alcohol, smoking, caffeinated beverages, etc. Let us see the introduction of GERD. GERD refers to the symptoms of mucosal damage that results from the abnormal reflux of the stomach contents into the esophagus. As we all know, the normal physiological process where the gastric contents move from the stomach into the small intestine and large intestine. Whereas in GERD, due to the abnormal reflux, the stomach contents enter into the esophagus. When the esophagus is repeatedly exposed to the reflux material for a prolonged period of time, inflammation of the esophagus takes place, which is also known as reflux esophagitis. It can progress to the erosion of the squamous epithelium of the esophagus, which is also known as erosive esophagitis. GERD not only associated with the esophagus, but it can also affect the other organs such as lungs, larynx, heart. It is referred as atypical, which is also known as extraesophageal reflux disease. Complications of long-term reflux may include the development of strictures, Barrett's esophagus, and adenocarcinoma. Complications are classified into grade 1, 2, 3, and 4. Grade 1 erythema, grade 2 linear non-confluent erosions, grade 3 circular confluent erosions, grade 4 stricture or Barrett esophagus. Erythema, it is a condition where we can observe the redness of the skin due to the continuous exposure to the gastric contents, whereas non-confluent erosions and confluent erosions is due to the damage to the tissue lining. Strictures are advanced form of esophagitis and are caused by the circumferential fibrosis due to the chronic deep injury. Strictures can result in dysphagia and a short esophagus. Barrett esophagus, it is a more serious complication of the gut. It is mainly present in 8 to 50% of the patient. It is thought to be caused by the chronic reflux of the gastric juice into the esophagus. It is defined as the conversion of the normal squamous epithelium into the columnar epithelium. GERD risk factors hiatus hernia. Here in the image, we can see the normal position and abnormal position of the stomach. Abnormal position of the stomach is seen in the patients who is associated with the chief complaints of chronic cough, vomiting, asthma. Due to the increase in the thoracic abdominal pressure, there is a bulging of the stomach into the esophagus, which leads to the hiatus hernia. Depending upon the severity, hiatus hernia is categorized into three grades. Obesity, it is a major risk factor which can lead to GERD. It is mainly caused due to the increase in the gastric pressure which causes the reflux of the gastric contents into the esophagus. When a patient who is obese approaches you with the chief complaints of odynophagia, dysphagia, heartburn, chest pain, etc., consider the waist to hip ratio rather than considering the BMI, which is known as the standard diagnosis for GERD. Lifestyle factors and medication. Some foods, including fatty foods, chocolate and peppermint, caffeine, alcohol, and cigarette smoking, can also cause the acid reflux and GERD. Certain medications also increase the risk of GERD. Medications like calcium channel blockers, beta agonists, alpha antagonists, oral contraceptives, tetracyclines, diazepam, which causes the mucosal injury and causes decrease in the lower esophageal sphincter pressure, which leads to LES hypotension. Clinical manifestations of GERD are classified into typical, atypical, alarm symptoms. Typical symptoms which may be aggravated by the activities and can be worsened. Typical symptoms include heartburn. Heartburn, it is the indication sign of the GERD. Water brush, it is known as hypersalivation, where the person feels the liquid is coming into the mouth from the esophagus. Belching of the stomach and regurgitation. Regurgitation is known as where the stomach contents are refluxed into the esophagus. Atypical symptoms, these are the extraesophageal symptoms, which are mainly diagnosed by the endoscopic studies. These include non-allergic asthma, chronic cough, hoarseness of the voice, pharyngitis, chest pain, dental erosions. Alarm symptoms, these symptoms may be indicative of complications of GERD, such as Barrett's esophagus, esophageal strictures, or esophageal cancer, adenocarcinoma. These symptoms include continuous pain, dysphagia, odynophagia, unexplained weight loss, and choking effect. Here we can see the visual representation of common symptoms: chest pain, belching, tooth erosion, hypersalivation, etc. Let us discuss the pathophysiology of gastroesophageal reflux disease. As we already discussed the etiological factors which can lead to GERD, like hiatal hernia, foods, and drugs, can lead to the lower esophageal sphincter relaxation. Prolonged period of esophageal sphincter relaxation will activate the hydrochloric acid in the stomach to increase the abdominal pressure, and which can lead to the anatomical changes. As there is a change in the abdominal pressure and anatomical changes, the esophagus gets damaged and gets inflamed, or the tissue gets damaged, which can lead to the complication of Barrett's esophagus or stricture esophagus. Diagnosis of GERD include CBP. In CBP, we should primarily consider platelet count and RBC rather than considering neutrophils and WBC. Chest X-ray, which is used to rule out the condition of hiatal hernia. Upper GI endoscopy, which is used to rule out the abnormalities in the esophagus. Ambulatory 24 hours pH monitoring, capsule pH monitoring. A probe is placed in the esophagus a distance of 5 mm away from the lower esophageal sphincter. The probe placed in the esophagus will monitor the pH changes in the stomach and esophagus. Ambulatory 24 hours pH monitoring is also associated with the risk factors for managing, so it is not widely used. So we are using capsule pH monitoring. In capsule pH monitoring, we will place a capsule in the esophagus which will monitor the pH changes in the stomach and esophagus for 48 hours. Pharmacological management of GERD include H2 blockers, histamine receptor 2 blockers, which is mainly used to decrease the gastric acid secretion. Drugs used are famotidine and cimetidine. Antacids, these are mainly used to neutralize the acid in the stomach. The drugs used are aluminum hydrochloride, magnesium hydrochloride, sodium bicarbonate. PPIs, proton pump inhibitors, which is mainly used to block the gastric acid secretion. The drugs used are pantoprazole, omeprazole, rapiprazole, etc. Prokinetics, which is mainly used to decrease the lower esophageal sphincter pressure. The drugs used are benzamide and domperidone. Non-pharmacological management of GERD include lifestyle changes like to lose weight, quit smoking, sleeping in an inclined position, modifying diet and food, avoiding eating meals at least 3 hours before going to bed, wearing loose-fitting clothes around the stomach. Diet plays a major role in controlling acid reflux symptoms. Foods to avoid are fried food, potato chips, and other processed snacks, chili powder, pepper, fatty meat, cheese. And foods that can cause the same problem include tomato based sauces, citrus fruits, peppermint, carbonated beverages. Foods to eat are ginger and curd. Ginger has an anti inflammatory property. Minimize the intake of salt in diet as much as possible. These root vegetables are good, like carrot and turnips, as they are having healthy carbohydrates. Hope the video is useful. Thanks for watching.